we're talking about precision medicine, how to use precision medicine in the clinic and what tools to use, and really to avoid bone marrow testing and use peripheral blood. So how do you think that's playing out, Jens?
Yeah, I think there's, right now it's getting close to being ready for prime time. And I think there's 3 options and 3 advantages and 3 scenarios in which blood biopsy is actually relevant. And the first one is what has been discussed in the session. If we have genes which are mutated, for example, with the BRAF V600E mutation, to use a targeted panel doing cell-free DNA and identify patients which have mutations in those genes, for which we have actually good drugs like BRAF and MEK inhibitors. The second scenario in which it might be useful is just to look at genomic evolution. And that can be done very cheaply and very quickly, for example, with low-pass whole genome sequencing. And that can be easily obtained at every relapse and with every treatment. And we can see how the disease evolves over time.
So if I'm getting this right, your technology is applicable when you have active disease. So you have a presentation and when you relapse, and so you can do molecular testing at those times. But then there are these big gaps where we're trying to cure people at some level. And so how did the technologies you two talked about play out in terms of applicability to the peripheral blood?
So in terms of, again, currently we have the assay using mass spectrometry just routinely available now at our institution. And so it's playing out in real life right now where we can have increased sensitivity and specificity of identifying and following the protein, a higher level of being able to detect MRD. Now, there are different levels of using mass spectrometry. We're currently using what's called top-down mass spectrometry, and we're using right now a MALDI-TOF, which is a machine that's only yay big that really can do high throughput. And so that's live now. The next level is using like a triple TOF or a more sophisticated mass spectrometer, where then if these are negative, then that could be applied, and that's less amenable to high throughput kinds of things. So it is playing out in real life. Then there's even one level further that you can go with mass spectrometry potentially, is by doing what's called bottom-up mass spectrometry, wherein you actually can specifically, so these other techniques are really identifying the mass, the size. You don't know exactly what the protein is, you don't know the VDJ or whatever. Another way is you can go bottom up, where you actually are looking for the VDJ, so you trypsinize and so forth, and then that may give, again, through the blood, a further sensitivity. Unfortunately with that, you do need a baseline sample of some size in order to, either you could have baseline VDJ from the bone marrow, because the sequence is going to be there, or if you had a big enough M spike at the beginning, you could even potentially get it from the blood.
So, like, that's very complicated for me. And so we have these kind of complicated theoretically, but very practical mass spec approaches, and then the sort of molecular approaches. How does your technology apply on the peripheral blood?
So the technology I was talking about is this VDJ tracking from the bone marrow. You can use VDJ tracking also in peripheral blood. The problem, if you're looking for minimal residual disease, is that there is not sufficient amount of DNA in the blood to reliably give you a true positive negative. You will have a lot of false negatives. There basically is too little material to reliably rule out detection of disease. So for right now, if you have these very sensitive VDJ assays, you have to do the biopsy with the current kind of standards we have. The way I think about it is that there are a couple of nuances, and all these technologies can be, in a way, used to address these nuances. One nuance, I think, is the diversity of the disease in a given patient. We know that there are many subclones in every patient, and I think Jens's technology can help us understand which combination of these subsets of disease does a given patient actually have to begin with, at diagnosis and maybe at relapse, and it could change over time. Angela and my technologies that we were talking about is more to look for, is there evidence, yes, no, of any residual disease after therapy has been completed? And I think in a way they are linked, but they are answering a little bit different questions.
So I think it all comes back to what I think the future of clinical myeloma is, which is treating patients to maximum response to obtain MRD negative states. So, like, what is the level of MRD that doctors in practice should aim for? Do we have any clue at this point in time?
I think the clinical guidelines we have worked out together, we published a couple of years ago, they say you rule out one cell in 100,000 in the bone marrow, that's good enough to call it minimal residual disease, and that's what we currently rely on for clinical trials. I'm quite convinced that that is going to change very soon. There is emerging data from many ongoing trials showing that if you jack it up to 1 cell in a million, you see a difference in progression-free survival. You start seeing some kind of plateau pattern for progression-free survival. But we don't know if 10 to minus 7 or 10 to minus 8 will get it even better. That's something we don't know.
So I have difficulties with the 10 to the minus 7, 10 to the minus 8, because I think you almost have to put a whole person into a machine to be able to have that level of sensitivity. So if 10 to the minus 6 is a kind of practical cut point, how do you think the mass spec plays out?
I don't have the answer to that yet. I know based on work we've done in myeloma that it definitely gets beyond 10 to the minus 4th and probably to close to 10 to the minus 5th, but we haven't done large enough series to really understand that. So I think that's a work in progress, but we definitely are getting there. And the nice thing too about the mass spec is it is specific. Therapeutic monoclonal antibodies don't get people confused because when you do immunofixation, you see a little G kappa floating around, and you don't know, is that the original? You do a shift assay, but then you have ilotuzumab, and what is that? And so the various antibodies. And so I think again we're on the pathway to have simple testing that actually gives you greater precision in deciding whether you do need to do a bone marrow, whether you do need to do a PET if you're really looking for MRD. And so potentially that'll make it easier on patients, if they don't have enough circulating, cell-free DNA or something that you can get from the peripheral blood. At least you can save a good fraction of patients from having to undergo that testing.
So how does this intraclonal heterogeneity play out in the context? I have some vision of, precision medicine, molecularly targeted medicine, where you monitor the clone with those molecular features. How are we going to monitor specific clones in remission states?
I think that's really, I agree with both Ola and Angela that the blood for detecting minimal residual disease, no matter what technology you use, is very challenging. But I think the blood biopsy techniques are very powerful when you look at every relapse when you have a lot of disease. So I think for monitoring, for precision medicine, for exactly those mutations that we are interested in, the blood biopsy has a real shot. And in terms of how we think about treating it, my personal bias is that precision medicine is probably ultimately going to be very good for cell reduction, but as monotherapy, it's not going to be powerful enough to really cure people or even reach an MRD stage. So I think we are basically going to chase the disease with every relapse.
Okay, so you kind of use your peripheral blood technologies when there's active disease, and then use more generalized mechanisms to monitor MRD states, either.
What I think is going to be really interesting. So there, these cases where you have patients that sort of, quote, return to the smoldering state. They may have, a persistent monoclonal protein, and yet they're doing great 15, 20 years later, and it's kind of mysterious. One of the things I think that we can answer now with these assays is that really the same clone? Is it a different clone? Is it something about the immune system that's keeping things in check? So I think, again, by having precision in knowing what the monoclonal protein is and precision in knowing what the clones are, I think it's going to give us the opportunity to study sort of relationships with the microenvironment, and do you always have to truly be MRD negative, or are there other things that may affect people being stable? And so getting rid of some of the background noise will be very helpful to that end.
So you can see we've had a really interesting session here. A lot of topics were covered, but we're really moving towards a situation where precision medicine is being introduced into the clinical management of myeloma patients, and we can only hope that that is really successful in improving patient outcomes. So thank you for your attention.